Thank you very much for the invitation, and it's quite hard to bring a technical topic close to a broader audience. I will try to do that. Let me start with something which is not on the slides. Why do we assess, or why do we want to assess medical technologies? The reason is to spend the available money, public money, in the most efficient way. And why do we focus on pharmaceuticals? I think that apart from the fact, or besides the fact that pharmaceuticals, innovative pharmaceuticals are expensive, it's important to note that it's a controlled market. Logistical and quality processes are quite standardized, and it's a proprietary technology. So unlike a surgical procedure, we have a realistic chance of arriving at a value assessment of pharmaceuticals. And in my presentation, I would like to do three things: show you a couple of general considerations, show you a model with 5 dimensions which might be suitable for the purpose in Serbia, and then to give you some examples of criteria that Serbia can realistically or usefully apply in the upcoming period. There are 3 approaches, and to pharmaceutical value assessment, and let me simplify. One approach is when we want to calculate as much as possible benefits and costs of medicines. This is the approach which is called economic evaluation, and this is the approach which health economists I think know most. This originates from the United Kingdom, and it's a methodology-heavy approach. If you look at the second approach, which is comparative assessment, it takes a bit different way of thinking. It takes on the regulatory process which the drug agencies normally apply, but it insists that there should be, when possible, an active comparator. So we compare the new technology to something which is already on the market and which is being used by medical specialists and patients. This is a more deliberative process. There are fewer standardized methodologies, and the archetype for this approach is perhaps France or Italy. And then there is, of course, a third approach, which is the combination of the previous two, and of course it's fair to ask the question whether this is an independent paradigm or not. The point here is that we can, and perhaps it's reasonable to combine the benefits or the positive elements from the previous 2 paradigms. And what I would like to emphasize that at this point it can become extremely complex, or it can become rather simple. If you have heard about multi-criteria decision analysis, which is a technical term, it's quite a complex methodology for trying to elicit those criteria and those weights which are relevant in decision making. What I'm going to present now, it's a much more, let's say, pragmatic solution, which tries to be in line with all those characteristics that we have heard in the previous presentations. I don't want to spend much time on the context assessment, but we know that there is a huge delay in pharmaceutical decision making. We saw the data, which is quite, let's say, a bit like disconcerting. And we may ask the question that if there are so many innovative drugs waiting for any decision, whether positive or negative, how can we help the decision makers prioritize in a way that they don't spend 6 years on it, but possibly a reasonable, limited, traceable amount of time? So we need a fit-for-purpose pragmatic system, which is not about science. And let me add up front that what comes is a model. It's an approach, but it's nothing like heavy science, and I don't think that in such a situation a public policy maker needs heavy science. There are certain variables, there are certain things that you need to decide when you think about pragmatic assessment. If you take a country where there are explicit health priorities, I think it's fair enough to start with those. And the first step in prioritization is to look at what governments have declared to be a primary health priority. In Central Europe, and this is not a Serbian characteristic, in Central Europe, governments tend to speak about priorities, but those priorities are not embedded in daily practice. So we say that we fight diabetes, and then what happens, who knows? We fight cancer, what happens, who knows? So I would assume it's better for Serbia to say that there are no explicit health priorities. And this is a fairer way to go on. And the other thing is that currently we are talking about a one-off prioritization and not a continuous management of the list. If the list, let's say, faces 20, 30 new molecules per year, you can think about more, let's say, deeper, perhaps, or more robust approaches. But when you want to tackle with 100x substances, if at all you want to do that, then you need to be rather pragmatic. What can we say as a mission statement? We want to enable clinical and economic assessment, both, because I will speak a word about it a bit later, in a decision-oriented way, so we don't want to create model science which are not necessary. In a resource-conscious way, we understand that there is a limited number of experts and resources available for this exercise, and we want to increase transparency and the speed of decision-making. And then we arrive at the model itself. Before the 5 dimensions that I briefly mentioned, let me share with you a couple of dilemmas that we have had during this development process. 6 questions. First question, cost effectiveness, which I would translate into value for money, worth buying, is a key term or a key concept in health economics. Do we need it as an explicit dimension? The let's say instinctive answer would be yes, we need it, because that's most in line with the goal of spending limited resources in a sensible way. But if we incorporate cost effectiveness analysis, there is a risk that we will need economic models to do that. And with economic models, there is a risk that we won't have data for them. And then we run, or Serbia would run the risk, which has happened in Hungary, Poland, and these are the two, or Slovakia to a certain extent, that there are models for decision making, and those models are partly populated, filled with data from abroad. So they don't show the local reality, and then decision makers decide based on them. I don't think it's fair. So it's not neither science nor pragmatic. The second, budget impact. Should it be part of the assessment model? Very simple answer. In an environment where governments, decision makers are mostly interested in budget, it has to be there. So we cannot avoid it. The question is how we incorporate it. The third, external benchmarks. Can they be used in Serbia? It's not a trivial question. In some cases, we have seen that referencing to other countries, it reduces the legitimacy of a certain model. We can say that, what works there doesn't necessarily work here. But we have also seen that referencing outside to markets or to countries which are more mature, sorry for the word, may help implement quick decisions. Fourth question. International reimbursement references. Are these applicable or not? I mean, whether a drug is funded already in a different country or not. This is, again, not clear because, sorry for my not too scientific way, but who cares? So if in Serbia we want to reimburse it, who cares whether it's reimbursed in other countries? But if Serbia doesn't reimburse anything, I think it may be worth having a look at the patterns outside the country. Social and ethical consideration. Here the intuitive answer is that yes, we need them. But if you look at the case of Romania, for example, you will see that the incorporation of these can lead to particular interests and can lead to a fragmentation of criteria, and then there will be a mess of criteria. And the result in Romania was that budget impact is the predominant thing, and the other dimensions cannot really counterbalance or offset it. And real-world evidence. Real-world evidence is a very valuable thing or a resource. It's extremely valuable. But in an environment where data availability is limited, it would be a bit too ambitious, perhaps, to start with a methodology which heavily relies on real-world evidence. First, it needs to be generated, and you need to have those structures in place which help that, and afterwards you can move on. And then after these dilemmas, which I have mentioned in quite a lengthy way, because I think it shows, now I can speed up, these result in these 5 dimensions: added clinical benefit, international funding and assessment references, national health policy alignment, social and ethical considerations, and for economics, there is no cost-effectiveness assessment because of the pragmatic objective. There is budget impact assessment only. And this is the outline of the scoring logic. Let me add one thing in brackets. In a pragmatic value assessment model or in a scoring model, if the model doesn't work, it's very, very easy to see. So for this, we have conducted a dry run on several molecules to test the model. In an economic model, if the model doesn't work, then it's hidden in the details, it's hidden in science, and you can't spot it that easily. So you may ask why 150 points. I could answer it can be 15. Perhaps it's more understandable and the proportions are easier to track with these scores. With these brackets closed, the scores are between 0 and 150, and a minimum of 60 points in this proposal or approach would be necessary for a molecule to gain conditional reimbursement in Serbia, and 90 points would be necessary to gain unconditional reimbursement. This means that either clinical benefit plus international funding references or economic benefit in itself could qualify a drug for conditional reimbursement. And if there are additional health policy alignment characteristics or social and ethical considerations, then the drug would theoretically and even practically reach the threshold needed for unconditional reimbursement. So this is the hidden logic, or not the hidden, this is the explicit logic of the model. And this is here in two ugly equations. Minimum score for benefit plus clinical benefit plus minimum score for references equals to budget impact assessment equals to minimum score for conditional reimbursement, and conditional reimbursement plus social ethical considerations plus health policy alignment would qualify the drug for unconditional reimbursement. In the model, we have proposed a slightly different framework for the clinical assessment of oncohematology medicines. The reason is I think it's very specific. In oncohematology, mostly for late-stage therapies, there are almost universally accepted endpoints, parameters for value assessment. Of course, there is an international debate whether it's overall survival, progression-free survival, but there are criteria, standardized criteria. This is one reason. The other reason is that almost 50% or even more than 50% of new drugs are registered in these indications. And payers are a bit sensitive to that and to the budget impact of these drugs. So a differentiated and even perhaps stronger or stricter approach may be necessary. And the last reason is that many of these drugs are available in special drug programs and not in the core pharma budget. Together to the criteria or to the dimensions, it's extremely important to talk about the process. And again, I would refer to the Romanian case. If there is no process, you can forget about any assessment. This is true for economic evaluation. This is true for a pragmatic value assessment system. In this process, we said that, and the core principle in this chart is that assessment and decision making is separated as much as possible. And decision-making has clear deadlines, and it's centralized in the hands of one committee, one decision-making body. The submission goes through the Republic expert committees. It goes through, I think it's newly to be established value assessment department, and then it reaches the Central Committee for Drugs. And the Central Committee for Drugs is not necessarily the same Central Committee for Drugs as today, regarding processes and operations. And we believe, now in this case let me say I believe, with my experience in Hungary as a payer, that if someone cannot decide in 2 or 3 sessions about the drug, they don't want to decide about it. So you can always decide about a product in 2 or 3 discussions if those discussions are well prepared. One more comment here, which is, I think, very important, is that Here at this point, the managed entry agreements, which have been mentioned, would be incorporated into the process. The reason is that all those, let's say, characteristics in pricing, confidentiality, which are relevant to Central Europe and which are related to the low prices, they can be managed only through confidential managed entry agreements. Managed entry agreements can be financial, can be outcome-based, but I think they form an integral part of any system, and there is a very good opportunity in linking value assessment to managed entry agreements. Value assessment is then an input to the negotiations, an objective or as much objective as possible type of input to the negotiations. I also believe that the process itself should be as transparent as possible, but there may be a lot of information, economic information, financial information, which is confidential. It's a good compromise. It may be a good compromise to summarize the publicly available information in a short report, which is the end product of the evaluation process and which makes details and information accessible to external stakeholders like patient groups, physicians, and wider society. And then, actually, the two facets of transparency are brought into harmony: process transparency, which should be maximum, and data transparency, which is necessarily limited in a middle-income environment. And now, assessment criteria, which is the last, let's say, block of my presentation. I mentioned the 5 dimensions, and I hope you can read them. There are distinct criteria in the 5 dimensions. Within added clinical benefit, we would start with the ability of a medicine to slow disease progression or to prevent the exacerbation of a disease. In oncology, there would be a slightly different criteria, as I mentioned. We would include improvement in the primary clinical endpoint. We would include improvement in the side effect profile. We would include improvement in patient convenience or adherence, and the availability of real-world evidence could be incorporated here as an auxiliary criterion. It's very important that these are sources of value for a new drug. In the second block, we would consider selected international funding and reimbursement references. One would be France, which is an archetype for the comparative assessment. Another one would be Germany, which is quite a specific system, and it's a combination, but economically conscious. The third would be Scotland, which is economic. And the fourth would be the availability of public funding for the drug in European Union member states in view of Serbia's approach to the European Union. When we look at national health policy alignment, then this dimension couldn't be the starting point, as I mentioned, but it's an important auxiliary dimension in the model. We would consider alignment with national health policy priorities if these are available. The prevention of causes of premature death in Serbia, the prevention of losing ability to work, so this is a broader economic criteria, and the release of public resources outside the RFZO budget. So if a drug saves money for families or in the social care system, we should consider it. In social and ethical considerations, there are a selected number of criteria like orphan designation, pediatric use, previous treatment experience in Serbia with alternative funding, no recent positive listing decisions. There are a couple of areas with this, and the impoverishing effect on patients, so the availability of co-payment and the level of co-payment. And finally, there is dimension 5, and sorry, it's not visible there, but that's the budget impact. And there would be a differentiated logic for negative, 0, slightly positive, highly positive budget impact. And a couple of examples as a closing slide. For each criterion in this model, there is a definition, there is a score. This score is binary, it can be full score or nothing. For certain criteria, there can be a partial score. And then there are data sources specified. The objective here is to have as little primary data gathering or research as possible, and to facilitate the evaluation, the assessment of medicines within a reasonable time frame, which is days and not months or not years. So this would be the proposal, this would be the idea, and during the further discussions, I think further details can be let's say, tackled and addressed. Thank you very much for your attention.